Also, don't want to forget that. So welcome everyone. I know a few of you are still joining us, but we will go ahead and get started so we keep everyone on time. My name is Elise Washington, and I'm a project manager supporting the Missouri Healthy Schools Initiative. Missouri Healthy Schools provides students with lifelong advantages built on early positive health behaviors to improve conditions for academic achievement. If you want more info, and I'll put this in the chat, check out mohealthyschools.com. We're super excited to have Rebecca Brown with us today. She's the Community Asthma Coordinator for Asthma Ready Communities. Rebecca is a respiratory therapist and certified asthma educator. She coordinates community-based asthma education delivery with schools and clinics and has been working with Asthma Ready Communities as a regional coordinator in the Kansas City region since 2012. Through that partnership, she's also worked with school districts with the Missouri Asthma Prevention and Control Program. Rebecca will be discussing the role of the school health office in helping a student and family recognize symptoms, understand their medication and how to use it properly, and help follow an asthma action plan. She'll share some tools you can use to help students achieve asthma control. We are in webinar mode, so your videos and microphones are off, but we will have time for Q&A at the end, and you can drop those in the chat or Q&A throughout. Don't want you to lose your thoughts waiting until the end. And I'll keep an eye on the chat and Q&A if there's anything particularly time sensitive that I can interrupt Rebecca and ask in real time. I will ask that you drop a note in the chat to share your name, where you're from, the area you're tuning in from, and your organization or role, so we kind of understand how you're connected to Missouri schools. Thank you, and welcome, Rebecca.
Thank you, Elise. I'm just going to dive right in to save on time, and so we have plenty of time for question and answer at the end. Asthma is a serious condition that affects more than 5.5 million children and is a leading cause of missed work and school days. Because of this, for health service staff members, including school nurses and other school health staff, the assessment of asthma symptoms and student asthma control has always been important. But it is even more so this year, as health staff will be challenged to determine if symptoms presenting are related to asthma or viral illness. Efforts to achieve good asthma control support the goals of better overall health, fewer symptoms, fewer absences, and a reduction in the number of visits to the school health office for quick relief medicine use. As I stated earlier, the school health service staff assessment of asthma symptoms has always been important, but it is now even more so, as they will need to determine if symptoms presenting are related to asthma or a viral illness. Asthma symptoms such as cough, shortness of breath, and chest tightness can be confused with symptoms of COVID-19. An asthma episode is uncomfortable and even frightening at times for the person who is experiencing it. However, in our current pandemic climate, it may also cause others around the symptomatic person to worry. The student experiencing asthma symptoms may be asked to leave to get a COVID-19 test or quarantine for 10 days from symptom onset before the child can return to school, which could also result in missed work for the caregivers. Additionally, nebulizer treatments used by someone with COVID-19 can spray the virus into the air, which could potentially infect others. Good asthma control decreases the risk of asthma flares, which require quick relief medication use, such as nebulizer treatments. Both the Centers for Disease Control and the American Academy of Pediatrics recommend the use of metered dose inhalers for MDIs with valved holding chamber for quick relief medication delivery during COVID-19, including with stock albuterol use. The bottom line is that good asthma control can help students stay safe during this difficult time and prevent breathing problems which might be confused with COVID-19. Monitoring daily health and taking medications as directed per the prescription in the asthma control plan should lessen asthma symptoms, reduce unscheduled visits to the health office, and prevent the use of riskier medicines like systemic steroid bursts, often associated with urgent or emergent care. Daily asthma control medicine use helps decrease airway swelling and limit sensitivity to asthma triggers, including cleaning agents, which is important as many schools have increased cleaning routines to minimize COVID-19 spread. These are priority messages that were identified by the EPR3 guidelines, the National Asthma Guidelines, for creating asthma-friendly schools. Focusing on these messages will help health service staff support students in achieving good asthma control. There are several ways school health staff can help students with asthma achieve good control, and they include: 1, assessing asthma control. And please note, during COVID-19, any forced expiratory efforts such as peak flow or forced expiratory volume in 1 second are discouraged at school due to the risk of spreading respiratory droplets. Tools such as evidence-based questionnaires like the Asthma Control Test or the American Academy of Pediatrics Instrument Child Health Survey for Asthma, which we will talk more about with the Teaming Up for Asthma Control program, assists school health staff in identifying students with poor asthma control. Remember, asking the right questions yields pertinent information. Consider frequent use of quick relief medicines. Ask the student open-ended questions. Asking the student open-ended questions will yield more honest responses. For example, instead of asking, "Are you taking your Flovent 2 puffs twice a day as prescribed?" ask instead, "What inhaler medications are you using? And how often are you using it or them?" 2, encourage and reinforce taking prescribed controller medicines every day to maintain control of asthma. 3, help students identify asthma triggers and teach ways to avoid exposure. 4, coach inhalation technique to increase the amount of inhaled medicine that reaches the lungs. And 5, obtain or fill out a generic asthma action plan for the family if needed. These messages are covered in the Asthma Ready Community's free training program, Teaming Up for Asthma Control. This program focuses on 4 key messages. Airflow must be measured to know how much asthma is limiting breathing. Inhaled corticosteroids must be taken every day to improve asthma control. Breathing medicines into the lungs requires practice and coaching, and triggers should be avoided to keep asthma from getting worse. This program comes with the free asthma tools, including a respiratory inhaler poster from the Allergy and Asthma Network Mothers of Asthmatics. If you are interested in signing up to take the 2-act course, visit asthmaready.org, Training Programs, and Teaming Up for Asthma Control, and then click the I'm Interested button. We mentioned assessing asthma control earlier, and that this year forced expiratory efforts are discouraged at school due to the risk of spreading respiratory droplets. Peak flows and FEV1s are being treated the same as nebulizers when it comes to recommendations for personal protective equipment, or PPE recommendations, and special room ventilation and cleaning. While forced exhalation, which includes peak expiratory flow and FEV1, is not considered an aerosol generating procedure, for some people this maneuver can trigger a cough, which has the potential to spread the virus into the air. Peak flows can be done at home, however, and some students might already have one at home. If you have access to peak flow meters, you can give one to a child who is a poor perceiver or not well controlled, especially if you think it is one who will use it regularly. And remember, guidelines recommend spirometry at least every 1 to 2 years for children 5 years and older with asthma. Encourage families to see their primary care provider for regular checkups. As previously stated, this year assessments are focusing on symptom-based questionnaires that are also evidence-based. The school is an excellent setting to use these asthma tools, as they can be done with social distancing because it is just asking some questions. A few of these evidence-based tools include the Asthma Control Test, the rule of two, and then in the TUAC COVID-19 checkup form, there are a few ways to assess asthma control. Assessing the use of quick relief medicine, asthma status questions, and the child health survey for asthma. The first tool we will talk about is the asthma control test. This questionnaire can be used on students ages 4 and up, although for ages 4 to 11, a parent or guardian needs to answer the last 3 questions, which can be done by phone. This is a validated questionnaire mentioned in the table of control in the National Asthma or the EPR3 guidelines. It asks questions about symptoms and frequency of occurrence, and it provides a score. If that score is 19 or less, the asthma is not well controlled. You can communicate the asthma control test with the score and symptom information to parents and the child's primary care provider if you have written permission from the parent or guardian to do so in an effort to support good asthma control. When time is short, the Baylor's rule of two with simple questions can help determine quickly whether or not time should be devoted to asthma self-management education like the Teaming Up for Asthma Control program. This tool is evidence-based and it's simple. A yes to any of the following questions means the asthma is not well controlled. Do you use your quick relief inhaler for symptoms more than twice a week? And remember, using the quick relief inhaler as pre-treatment before activity would not count as being used for symptoms. Do you wake up at night from asthma more than 2 times a month? Do you refill your quick relief inhaler more than 2 times a year? Measure your peak flow at least 2 times 10 or 20% from baseline with asthma symptoms. And basically what that means is having a peak flow less than 80% from baseline, which could be personal best or predicted value. This is the COVID-19 Teaming Up for Asthma Control checkup form for the 2020-2021 school year. With written permission from the parent or guardian, it can also be shared with the child's provider. This form provides several ways to assess asthma control. One way this form can be used to assess asthma control is to ask about the frequency of quick relief medicine use. More than twice a week for symptoms indicates a lack of control. Remember the rule of two. It is really helpful and eye-opening to ask about quick reliever use in an open-ended way. For example, how many times a day or week are you using the quick relief medicine? What do you use it for? For example, is it being used for symptoms or pre-treatment before sports or physical activity? Or are they taking it for control, perhaps out of confusion? Remember, use more than twice a week for symptoms indicates that the asthma is not well controlled. And daily use for symptoms is worrisome and suggests a student is at higher risk for an asthma-related emergency. Asthma status questions also included in the TUAC COVID-19 checkup form. Answering yes to any of the following questions indicates a lack of asthma control. 2 of the questions follow the rule of 2 and are also in line with the national guidelines on control based on symptom frequency. Use of quick relief medicine more than twice weekly, and waking up at night from asthma symptoms more than twice a month. The Child Health Survey for Asthma, which is from the American Academy of Pediatrics, is a validated questionnaire used in the Teaming Up for Asthma Control program that can be used by a child as young as 5 without the parent present, which can be a little bit easier in the school setting. There is a scale for questions 3, 4, and 5 that indicates asthma control, and they are weighted based on the frequency of symptoms. The questions use a Likert scale and includes the following responses: not at all, a little bit, some, a lot, or totally. We have talked a little bit about being able to share information with providers with written permission. This FERPA form, which is available for download at schoolnurselink.com, can be sent home for parent signature, and then if obtained, allows health service staff to share medical information with the child's provider. This form is not exclusive to asthma, but it would cover sharing information about asthma with a provider. An important part of good control is control medication adherence when it is prescribed. Emphasize the importance of using controller medicine with inhaled corticosteroids, or ICS for short, as prescribed, which is usually twice daily, especially if the child's asthma is not well controlled. Frequently, the ICS controller medication is not taken as prescribed, and too often the asthma does not get better. Control medicine works slowly. It takes time to notice improvements in asthma control effects. Usually at least 2 to 3 months to achieve better control, which also means using 2 to 3 controller inhalers during that time frame. It takes weeks to heal airway swelling and restore normal airway lining, like the growing back of the cilia on the lining, and also to improve lung function. ICS also requires consistent daily use in order to keep working. And after that, it is usually needed to be continued in order to maintain good control. Consistent ICS use prevents asthma episodes and emergencies because it decreases the swelling that causes the airway to be twitchy and overreact to triggers such as viral infections or allergens. Children and adults often confuse which inhaler is for daily or quick relief use. Talk to parents and students about their medication and how it should be used to achieve good asthma control. You can talk to them about their asthma medication use using a respiratory inhaler chart. Many children and adults do not know the names of their inhalers, but they can identify them by picture, and a respiratory inhaler chart provides just that. You can get one by either ordering it for $5 from the Allergy and Asthma Network Mothers of Asthmatics online shop. The one we're showing here is the respiratory inhaler side-by-side 33 by 17 inch. Another way to get a poster is by taking the free Teaming Up for Asthma Control course offered by Asthma Ready Communities that we talked about earlier. Any school health service staff in Missouri who completes the course can get a free respiratory inhaler chart. When asking a child questions about their asthma medication use, it is great to start the conversation using open-ended questions, as we've mentioned already, to get more accurate responses. But if a child is having trouble thinking of a response, you can provide multiple choices to help. Not only will it help to determine adherence, but it provides an excellent teaching opportunity. Here's how the Teaming Up for Asthma Control checkup form guides questions to determine adherence. Start by asking the student which asthma medications are being used and how often they use them. Control asthma medications are usually ordered twice daily. On the respiratory inhaler chart, they are labeled as inhaled corticosteroids, combination medications, and occasionally muscarinic antagonists or anticholinergic inhalers. If the student identifies a control inhaler, ask how often it is supposed to be used. And if this is not known, the information can be found on the prescription label on the box the inhaler comes in. Also ask how many times the inhaler was used this week. If the student is not sure, you can give choices such as taking it once daily, twice daily, or with trouble breathing. If the student indicates daily, you can ask then how many times it was taken or missed in the last week. Document these answers given and talk about it with parents, and with written permission from the parent or guardian, you can share these responses with the provider, with the checkup form. It could be that the child recognizes a controller inhaler on the medication poster and they are not currently taking it. In addition to it possibly not being prescribed anymore, there could be barriers to them taking it that have not been uncovered by the primary care provider. Perhaps they need help signing up for Medicaid, and there could be someone at your school district who can help with that enrollment. Additionally, they may not be picking up the medication because of the cost, if they have private insurance or no insurance at all. If cost is the barrier, there are a few options that can be explored. Their insurance formulary may cover a different brand of control medication, for instance, Flovent versus Asthma-Nex. Check out prescription assistant programs such as through Merck. Check for coupons by inhaler manufacturer or GoodRx or Single Care. Also check to see if the student's provider has access to inhaler samples. Another alternative that a child's provider could help with is increasing the dosing amount per puff so that a control inhaler can last 60 days rather than 30. Another barrier to ICS adherence is that the family may not understand that even though it is not working right away, like the rescue inhaler seems to, it will still help them. It just works more slowly and takes more time to feel the effects. Another common barrier is a fear of side effects caused by the tiny amount of steroids in the daily controller inhalers because of that word, steroids. The fear of steroids is prevalent even among parents who take their child to the emergency department at least once a year or every other year. What they oftentimes do not realize is that when they do this, their child is receiving more steroids in that burst of injectable or oral steroids, like prednisolone, given in the emergency department for asthma than they would if they were taking their controller inhaler daily, an act that conversely would help keep them out of the emergency department. It would take more than 2 years of taking the daily ICS before equaling one of those stronger doses of more risky steroid bursts given in the emergency department. In addition to being smaller doses, the ICS goes to the lungs instead of the whole body, like the steroid bursts do. Oftentimes, once parents understand this, they are more open to giving the daily controller to their child as prescribed. Oops. This advice comes from the American Academy of Pediatrics COVID-19 Consideration Guidance for School Reentry. Schools should work to develop and implement asthma action plans, which may include directly observed controller medication administration in school to promote optimal asthma control. This advice advocates for the administration of controller medication use at school in some situations to help some students achieve better adherence in an attempt to achieve good control, especially during this time of COVID-19. This will not be for everyone, but if they can't get good control and are not having good adherence at home, always consider having them come into your office to take the controller medicine. It is a way to guarantee they will get it at least on some days they come to school. And that may be better than what they can achieve at home. You may start to see some students also carrying certain inhalers traditionally thought of as inhalers only used for control, as the inhaler they are also using for their quick relief medicine. We will talk more about that in a little bit when we talk about smart therapy, but just something to be aware of. If a student is taking control medicines daily, but their asthma is still not well controlled, improper inhalation technique may be a reason why. Always check inhalation technique. And if a child is taking their asthma medications incorrectly, they are not getting the full benefit of the medicine. Whether practicing in an attempt to support good asthma control or in an emergent situation, inhalation technique is incredibly important. One important aspect of inhalation technique is the use of the valve holding chamber. Valve holding chambers help ensure more medicine reaches the lungs when using a meter dose inhaler, or MDI. A valve holding chamber prevents medication plumes from a meter dose inhaler from striking the mouth at 40 miles per hour. MDI medications taken without a valve holding chamber largely end up in the mouth, throat, and ultimately the stomach. The valve allows a breath to be taken in through the chamber, but prevents exhaled air from flowing back into the chamber and washing out the medication. The prevention of air flowing back into the chamber also helps in the prevention of cross-contamination in the case of a stock albuterol MDI at school. Most VHCs, or valve holding chambers, are equipped with a whistle or a flow signal to warn users when they are inhaling at twice the ideal speed. The whistle means to slow down. Another key aspect of inhalation technique boils down to airway mechanics and coordination. To help everyone understand how to achieve this goal, we can keep it simple. Hold air out, aim up, and breathe in slowly. Again, if you hear a whistle with the valve holding chamber, slow down and take longer to fill the lungs next time. Students can practice this without medication. The target inhalation time, or breath in, when breathing in the medicine from an inhaler, is another important aspect of inhalation technique. The amount of time that should be spent inhaling medicines to fill the lungs is based on the size of the lungs, which grows with age and height. A quick average guide is 2 to 3 seconds for elementary age students, 4 to 6 seconds for middle school students, and 6 to 10 seconds for high school students. Target inhalation time is the amount of time that medicine should be inhaled and is based on the size of the lungs. The formula for target inhalation time for meter dose inhalers is 2 times the FEV1, or the forced expiratory volume, over 1 second. During this COVID-19 pandemic, while performing expiratory efforts in the health office are not encouraged, it is easy to stick with an average target time based on age ranges that we just mentioned. Again, for elementary age students, that's about 2 to 3 seconds, middle school 4 to 6, and high school 6 to 10 seconds. But know that there is an option to get a more specific predicted target time based on the predicted FEV1. This is something to think about with children who are shorter or taller than average to find a more accurate target time that takes height into account, in addition to the age. The more specific target times based on the predicted FEV1 would be 2 times the predicted FEV1. This predicted value can be calculated using this online calculator right here and down here, and also is available in the reference section. It is online, and you can go and enter a student's information in and determine their predicted FEV1. An asthma action plan is a written document given to the patient, family, or caregiver, which helps to reinforce agreed upon goals and expectations of treatment while encouraging self-efficacy in the management of asthma. It serves as a communication tool between the school health service staff, the parent, and the provider, and the student. The asthma action plan incorporates self-monitoring of symptoms, triggers, and peak expiratory flow with proper medical and medication management. Allergy and irritant trigger management can also be included. The treatment plan is divided up into 3 zones. The green, you take this medicine every day, even if you're feeling well, or do this every day, even if you're feeling well. It doesn't always have to include medicine use. For the yellow zone, for management of mild to moderate asthma symptoms, you would take this medication when symptoms start to arise. And in the red zone, for management of severe asthma symptoms or emergencies, where 911 call may be in order. All patients and students should receive a written asthma action plan and tells them how to take daily actions to control asthma. Frequently, asthma action plans come from the clinics, but they can be completed by a school nurse, by a school service staff member with known medication prescriptions. They have peak flows and FEV1 ranges, and that can be based on predicted values or the best on record. They have yellow zone actions, as well as indications for a 911 call, as previously mentioned, and the correlating use of 6 puffs of albuterol bivalve holding chamber for life-threatening emergencies. A printed asthma action plan ideally will have clinic contact information listed. Details of asthma action plans should be reviewed with the students, patients, and caregivers with ample opportunity for the family to ask questions. Again, school health service staff can help with this if it has not already been done. It's important to use teach back, where you ask the student or parent to teach the components of the plan back to you to ensure understanding and to confirm knowledge and recognition of signs representing the green, yellow, and red zones. Teach back will also help make sure the actions correlated with each zone are understood. With consent, assure asthma action plans are available to the following school staff: health service staff, of course, teachers, coaches, and childcare or after-school care workers. This comes out of the National Asthma Guidelines, the EPR3 guidelines, and has some key points. Develop a written asthma action plan in partnership with the patient or family. Teach patients how to use their asthma action plan and integrate education into all points of care involving interactions with patients. So this absolutely includes the school as one of those places. And this is the same advice we talked about earlier from the American Academy of Pediatrics for the COVID-19 reentry. One part of this statement pertains to asthma action plans and indicates that schools would work to develop as well as implement them. And what this means is that an asthma action plan does not have to be created by a provider. If they have one already, there is no need to recreate one or develop a new one. If there is not one available, though, you can develop one with known asthma medication prescriptions. If the school health staff is able to find out what the prescription labels for asthma medications say, which may involve getting that information from a student's family, an asthma action plan can be developed. This is an asthma action plan from the American Academy of Allergy, Asthma, and Immunology, showing the green, yellow, and red zones. It is a fillable PDF, and you can download it from the website referenced here, and also there is a list of references at the end of the presentation. This is another asthma action plan that is also a fillable PDF that is provided from the National Heart, Lung, and Blood Institute. Additionally, you can find this on the asthma page of the Missouri Healthy Schools website. You can download it from there too. Now we are going to switch gears and look at recent updates in asthma management. In December 2020, there was an update to the National Asthma Guidelines. This is called the 2020 Focused Updates to the Asthma Management Guidelines. It is not a rewriting of the National Asthma Guidelines. It does involve modifications to the stepwise approach for treating asthma. The 2007 EPR3 remains the primary guide to approaching the diagnosis and management of asthma, like with the assignment of asthma severity and control, but there are a few areas that have been updated and modified. And they include intermittent inhaled corticosteroid use, long-acting muscarinic antagonists or LAMAs, indoor allergen reduction, immunotherapy, fractional exhaled nitric oxide, and bronchial thermoplasty. We won't have time to delve into all of these topics today, but I've taken out a few points that seem most relevant to school health staff. This is the address to the digital toolkit for the 2020 focused updates to the asthma management guidelines. You will be able to find resources that help break down the 2020 focused updates to the asthma management guidelines. There are multiple short and free resources, including 7 fact sheets on the updated subjects and a clinician's guide. I'm going to go through these slides a little quickly to save time for questions afterwards, but this PowerPoint will be available to all participants. A link to a shared folder with these documents will be available and sent in the follow-up email from this webinar. If you go to the website listed in this PowerPoint, you will be able to download the documents in the toolkit. These are some of the fact sheets available on that website. These are resources that are short summaries you can download related to the changes in the updates. Some of the fact sheets include the changing role of ICS in asthma management, reducing allergens, and immunotherapy. There is also a wonderful clinician's guide, a synopsis that is 16 pages, and you can read it in about an hour. These are the 3 tables included in it for the stepwise approach to the management of asthma in the 2020 focused updates to asthma management guidelines for the following age groups: 0 to 4, 5 to 11, and 12 and up. This is a quick summary of the EPR3 guidelines that came out in 2007 for the diagnosis and management of asthma. It is only about 12 pages long and can be read in about an hour. Keep in mind the original EPR3 guidelines are much longer than this, over 300 pages long, but this is a good summary. And this serves as a primary guide to follow with regards to the diagnosis and management of asthma, including, as previously stated, the assignment of severity and control. Those tables given in this guide are still relevant. Also, this is one of the documents available to participants registered for this webinar in the link that will be sent in the follow-up email, and also the clinician's guide we just talked about. On page 7 of the Asthma Care Quick Reference Guide, where the step therapy is introduced, is where you start referring to updates with the stepwise approach. That starts on page 11 of the clinician's guide in the 2020 focused updates. That is another document, as I just stated, that will also be available to participants. This is one of the tables for the stepwise approach to managing asthma. It is for the age group 5 to 11, this table. The darker green row lists the preferred treatment methods for the 6 steps of asthma treatment. And this slide has circled steps 3 and 4, which include SMART therapy, which we will talk about more in a few slides. Included, we talked about the intermittent use of inhaled corticosteroids. So with the new update in children ages 0 to 4 years with recurrent wheezing, a short 7 to 10 day course of daily inhaled corticosteroids, along with an as-needed short-acting beta bronchodilator such as albuterol sulfate, is recommended at the start of a respiratory tract infection. In people ages 4 years and older with mild to moderate persistent asthma who use inhaled corticosteroids daily, increasing the regular inhaled corticosteroid dose for short periods is not recommended when symptoms increase or peak flows decrease. For people ages 4 and older with moderate to severe persistent asthma, the preferred treatment is a single inhaler that contains an inhaled corticosteroid and the bronchodilator formoterol. This should be used as both a daily asthma controller and quick relief therapy. So the SMART therapy we've mentioned is a single maintenance and reliever therapy. People ages 12 and older with mild persistent asthma may benefit from inhaled corticosteroids with short-acting bronchodilator for quick relief. Treatment may include inhaled corticosteroids daily or as needed when asthma gets worse. So this new approach to therapy is relevant for the age groups 4 and older who have moderate to severe asthma, and you may see some of your students following this regimen called SMART therapy. Again, that's single maintenance and reliever therapy. And what that means is that one inhaler is going to serve 2 purposes for a select group of patients or students. So that inhaler would be both for anti-inflammatory as well as providing some relief from bronchospasm and the associated symptoms of asthma episodes. Essentially, you might see someone pulling out an inhaler for quick relief that is not albuterol. If it is Dulair or Symbicort, it will be in accordance with the new guidelines. These are the only two inhalers that have the long-acting beta-2 agonist from Motorol, and the only two that are approved for this SMART therapy. Other combination medications with a different long-acting beta-2 agonist, salmeterol, cannot be used for SMART therapy. They do not work the same way as formoterol does to relieve bronchospasm. So a medication like Advair would not be used for SMART therapy. You will likely still see a lot of albuterol inhalers at school, as these guidelines are new, and the out-of-pocket cost for the inhalers used for SMART therapy will be a barrier for some. The maximum amount of medicine that should be used in a day when using SMART therapy is 8 puffs for the 5 to 11 age group and 12 puffs for the 12 and up age group. The Dulera and Symbicort on the left are the only two inhalers you will currently see being used for SMART therapy. You may see a student using one of these two inhalers as a quick reliever, as well as for their control. They may come in different dosing of ICS medications. The LAMA inhalers that you see on the right-hand side, you will likely not see in school, as they would not be used for quick relief therapy, but you may have a small number of students who identify it on the respiratory inhaler chart. With LAMAs, or long-acting muscarinic antagonists, if inhaled corticosteroids alone do not control asthma, a healthcare provider may add a long-acting bronchodilator, such as a long-acting beta-2 agonist, or LABA, and that would be the formoterol or the salmeterol we talked about, or a LAMA. For children under 12 and most people ages 12 and older with asthma, that is not controlled by an inhaled corticosteroid alone. Adding a LABA rather than a LAMA to an inhaled corticosteroid is preferred. For people 12 years and older, if a LABA cannot be used, a LAMA may be used with inhaled corticosteroids instead of using the inhaled corticosteroid alone. For people 12 years and older whose asthma is not controlled with an inhaled corticosteroid plus a LABA, adding a LAMA is recommended. So what is important to understand here is that you may have a small number of students who report using a LAMA in the 12 and older age group, and it will not be prescribed very often. Using multiple strategies are recommended to reduce indoor allergens when there is a known sensitivity. Allergy testing detects sensitivities and can help target efforts and resources, which can be costly and are not recommended for people who are not allergic to indoor substances. Examples of these strategies include air purifiers, HEPA vacuum cleaners, pillow and mattress covers that prevent dust mites from going through them, and integrated pest management. And that concludes this portion of the webinar, but we are opening this up now for questions and answers. And I also want to take some time to introduce Tammy Rood, Dr. Tammy Rood, who is here to help with the question and answer session. Tammy, do you want to introduce yourself?
Sure. Hi, everybody. My name is Tammy Rood. I am a pediatric nurse practitioner and certified asthma educator. Work here at the University of Missouri in Columbia. As Rebecca discussed guidelines, we are, as clinicians, just starting to get used to this SMART therapy and adjusting our treatment plans. But I'm happy to answer any questions that you might have.
So I see we have a lot of school nurses on our line. We had them drop into the chat their roles. So I'm encouraging anyone, if you have questions, feel free to put them in the chat or Q&A. One thing I'm curious about as I hear this, because there's so much, information to consider when dealing with asthma control. Have there been particular concerns that have come up specifically in COVID? Like, I know we've spoken broadly about when a kid coughs near someone right now, there's some paranoia, but particularly in the school asthma control setting, have there been some additional like emergent issues or examples you can share that have come up, questions you've gotten frequently? And that can go to either of you.
Yeah. I think the biggest question that I have had is just having some students that don't want to wear a mask because they feel like it is harder to breathe with wearing a mask. And really the message that we relay is that even though you have asthma, you should still be able to wear a mask. The key is that you find one that is most comfortable for you. And like anything else that is new, it takes practice to get used to it. So we really are encouraging our families that they need to wear the mask at school, that if this is a worry, that they have a safe spot that they can take the mask down for a moment, be able to breathe and become comfortable again. But really the goal is to wear the mask at school. I probably think that's one of the biggest concerns that I've had from families related to the school setting. Honestly, this year, I feel like many of our patients feel like their asthma is so much better controlled because they are either learning virtually online, they've not been exposed to as many triggers. So, and missing the fall of the year, fall is typically a big risk with the seasonal changes and all the viral illnesses. I don't know, I'm curious to hear from school nurses what they are hearing from their asthma patients as a concern or worry.
I agree.
We do recommend the mask that you would wear over your nose and mouth and not a face shield. Too, you know, as we talk about the mask, we usually try to give them I think the American Academy of Pediatrics has some great resources on how to talk to people about wearing a mask. Children are pretty resilient. I think they do really well, especially if they have parents and other caregivers that are wearing the mask and teaching them, showing them good being good role models.
I just noticed in the news the trend towards recommending the N95 mask, where, you know, because when last March, when all this happened, I mean, you couldn't find masks. I was ordering them from Etsy, and my friends are making bandana face coverings because they were all sold out. But now it seems that more options are readily available. So are they recommending N95s for children too, or is there any guidance on that?
Not that I know of. I know we've heard some discussion about double masking, and I do worry about I think that's going to be another challenge to try to talk to families. It's hard enough to get them to wear one mask and be consistent about wearing it, you know, especially wearing it on the school bus or when they're in rooms close to people, but two masks, they're not ready for that conversation. That's going to take a lot more explanation and encouragement to get people to do that. Honestly, all the kids that I see, that the majority of them do very well. You know, there's a variety of different masks out there. You just have to find the one that is most comfortable for you. If it's the pleated kind, if it's, you know, cloth versus the different types.
I found I don't like the cloth, the heavier cloth. I prefer the disposable
or the medical. Yeah,
exactly. Because the cloth are the ones that like I started breaking out, which, you know, like, it just was not easy again. So I imagine kids can be kind of the same way about that sort of thing.
I think people forget to look at their inhalers and check the expiration dates. Check the dose counters to make sure they really have medicine in there. Remember that for their quick relief inhalers, that if you haven't used it for 2 weeks, you have to spray it 3 or 4 times to prime the medicine so you get a good amount that will help you breathe better. So that would be another thing that I think has been forgotten with people doing so well over COVID.
And you mentioned, because typically the fall, it's cold and flu season too. So you have these other triggers. In y'all's experience or what you've heard from schools, has there been overall lower rates, I assume, of the flu and cold because they're virtual or partly virtual or they're wearing masks?
Wearing a mask,
okay.
Yeah.
Mm-hmm.
Yeah. And so we would tell you a lot of people have cold air as an asthma trigger. And before COVID, we would tell you to wear a mask when you go outside in the cold air.
Just to keep it from,
yeah.
It works.
That's awesome. I hadn't even considered that before. And now hopefully it's a little easier for, kids dealing with asthma if everyone around them is wearing a mask too, right? That doesn't feel as
exactly
you're ostracizing.
Exactly.
Right.
And I think also a lot of families are being more proactive with taking their controller asthma medicine with COVID, wanting to stay healthy.
Right, because you also don't want to have to go to the hospital right now. Visitation rules are much more restrictive and nobody wants to be in the hospital space right now. I mean, not that you do normally, but I think especially now it's hard, on families when there's visitor restrictions or anything like that.
And we try to message families that this, just because they need medicine now doesn't mean that's forever and ever and ever. We want to have you on the right amount of medication to avoid you having symptoms or attacks. And then once you have good control for at least 3 months, we're going to step down. And some of the key things to get you there are really working on good inhaler technique, which Rebecca did a great job talking about that, because these are key medicines that are going to improve your asthma, but it's a skill that takes practice and coaching to get them into the lungs so that they work. And then thinking about the nose is so important to asthma. We're coming up when it's warming up a little bit this week, tree pollen is going to start being an issue. So if you're tree sensitive, learning how to clear out your nose with salt water, using your nasal steroid if you need it, using your antihistamine. If you can take care of your nose and breathe in your medicines the best way, people get better faster and can be on less medicine. So
that's awesome. We don't have any questions coming through. I know someone had earlier asked about if they would get the slides. So I did also let them know in the chat that we will be sending out here in about 3 or 4 days, a follow-up email will go out and there will be a link because it has a folder that has Rebecca's slides as well as the different resources she mentioned. If you have any trouble accessing that, because we don't normally share in folders, but because it was so many documents, feel free to send us an email at info@mohealthyschools.com. I do see a question in the chat now. Do clinicians still go by the rule of twos?
Absolutely, Janet. Absolutely still go by the rules of twos because it still falls in line with what the asthma guidelines are saying. So are you having trouble breathing more than 2 days a week? Using your albuterol often, it's looking at measures of airflow. So yes, absolutely. Like Rebecca said, it's a quick and easy way to try to get an understanding if somebody's controlled or not. And I think many people, asthma is not much different than some other chronic conditions where people just accept a lot of symptoms because they think that's normal because they have this condition. So I have asthma, so it's normal that I wake up 3 or 4 nights a week. Well, that's not the expectation. The goal is that we can have you on medication that you sleep through the night and you're not waking up more than 2 nights a month. So I think working through those expectations and doing that education is important.
Yeah, and she mentions that she uses the rule of twos to talk to her parents to gauge how controlled they are.
Yeah, I like that.
Mm-hmm.
Yeah. I would say it's probably a little bit more of a conversational tool. Just because like with the asthma control test, you've got specific questions and it's a form that you follow. With the rule of and you have a place to put the responses on that form. Whereas with the rule of two, we don't necessarily have a form to follow, but it's pretty easy. And then in our Teaming Up for Asthma Control checkup form, we do incorporate some of the rule of two in there, so that it still incorporates it, and it's a form that can be checked and written on, and then also hopefully ideally shared with the parent and possibly even the provider with written permission from the parent or guardian.
Awesome.
I think the big message is asthma, the expectation is asthma management has come so far that asthma should be controlled, but like any other chronic condition, there's so many key messages and there's so many skills that you have to learn that it takes many people delivering those same messages over and over for it to kind of click and for people to get it. So that's why it's so important. Gosh, we really value what school nurses do to try to help reinforce those messages, to make sure, I mean, the goal is that kids are normal, active, they don't have to miss school because of their asthma. They can sleep through the night, and nobody should know that they have asthma if we have them on a good plan. So I just think kids are like adults. It takes us several times of hearing the same message for it to finally click. You can only absorb maybe one or two things, and you need to keep hearing those messages over and over for you to learn it.
Right. And so if you feel like you're getting resistance from parents or that they're just not hearing you, don't give up. You sometimes just hearing it a few more times from you, or maybe trying to explain it in a little bit different way, especially if it comes at the right time. If a child is, coming to you short of breath, that might be a really good time to try that messaging again.
And as Janet says, they should absolutely be able to do PE, even if you have asthma. We definitely say you should be able to keep up with other kids your same age and size. That's the expectation.
Be able to play in all the sports.
Yes.
Jackie Joyner Kersey has asthma.
Wow. Yeah, I think that's such a different message, because I mean, I remember even when I grew up, like when someone, no, I can't do that game, I have asthma. You heard that message so much from kids. And I mean, that was a while ago that I was in school, but it sounds like that message is still kind of prevalent. So part of the work is telling people, like, no, you can expect to have better involvement and not be worried about asthma.
Do whatever sport or instrument or activity you choose to do. Asthma should not slow you down.
Awesome. Well, we're about 2 minutes to 5 o'clock. I don't see any more questions right now. Again, if you have follow-up questions that you guys want us to pass along to Rebecca or Tammy, please send us an email at info@mohealthyschools.com, and we'll be sure to connect with them and follow up. We're always happy to share information. And I know Rebecca mentioned both School Nurse Link as well as the Healthy Schools website, which I dropped both of those in the chat. But I highly recommend checking those out for different resources for educators and school staff. Tons of stuff, I'm going to plug Mo Healthy Schools, a lot of content coming out through social media. If you follow them on Twitter, we also have a newsletter that at mohealthyschools.com, you can sign up to get that newsletter. And we send that every other week or so to share resource and highlight new videos or content that we have. All right. Well, thank you so much for y'all being here today. I appreciate it. This was great. And I will talk to you all soon.
Everybody.